jumping on to Unit 2C, we're going to be discussing dystocia and electronic monitoring during labor. We're going to go ahead and begin with dystocia. Now, dystocia is a really fancy word for a dysfunctional labor, or a dysfunctional labor. You might hear it on the postpartum unit or even on the labor unit as being termed failure to progress. So for some reason or another, labor has stalled. It's somehow become abnormal. It might be extended because of that stalling, might be long. It's abnormally and unanticipated to be more difficult. It's caused by one of those 5 factors that we discussed regarding labor. However, with that being said, dystocia usually is going to occur in the active phase of that first stage of labor, so 4 centimeters or greater. Now, when we're talking about dystocia related to the powers, remember we're talking about those contractions. So we have some sort of abnormal contraction that is preventing the normal progression of dilation, effacement, or even fetal descent. So there's a hypertonic uterine contraction that would be considered a dystocia, a labor dystocia. So hypertonic uterine contractions, now I realize that I just said that this typically happens at 4 centimeters or greater, but when we're speaking about hypertonic contractions, these are usually occurring during more of that supposed latent phase from those 0 to 3 centimeters of dilation. These contractions are very, very frequent, but they're ineffective. They're really not causing any of that dilation and effacement. They're not really pushing that fetal head towards the cervix to actively cause that progression. The uterus, the problem with this is that, remember when we talked about that uterine tachysystole and that would be a potential side effect of Pitocin? Okay, it's the same kind of concept here. We have a uterus that's contracting much too quickly. And just as with any other muscle in the body, when we have a muscle that's contracting too quickly, it's not relaxing in between those contractions and allowing for that perfusion. If the uterus isn't being perfused, the placenta isn't being perfused, and the fetus is not being perfused. So the fetus is being deprived of adequate amounts of oxygen. The force of the contraction here, part of the reason that it's not forcing that fetal head is because these contractions are starting at the midsection, kind of where that Bandel's ring is. It's starting at the midsection of the uterus instead of at the top where the fundus is. And so again, there's that lack of downward pressure, right, to progress our labor. So what are we going to do? Well, remember when we were talking about sedatives in labor? This is the one time, or maybe I get to it next. This is the one time where we will give a sedative, okay? This is the one time where we might give something to help mom relax, sleep, and that will also cause the uterine contractions, hopefully, to revert back to a normal pattern. We're going to encourage therapeutic rest. We're going to do everything that we can to create a calming atmosphere. We don't want to do any kind of uterine irritation. We're going to give maybe a bath if her waters haven't broken, analgesics, and then we're going to frequently reeval this fetal heart rate. Again, if this heart rate starts to do something funky where we're not comfortable with it, we're going to progress straight to a C-section. Healthy mom, healthy baby. That's our goal, right? Hypotonic contractions are kind of the opposite. So again, they're ineffective, but these are very weak. In this case, the uterus just decides to peter out. It's over this. It's way done. This occurs typically during the active phase of labor, so between the 4 to 7 centimeters time phase. Can be due to poor positioning of the fetus. So is this a breech baby, or is there some what we call cephalopelvic disproportion, or CPD, which we will be talking about. If all is normal with this delivery, with everything else, as far as we can see with our assessment, at this point we're going to try to wake that uterus back up. If this baby is, vertex delivery, everything otherwise seems to be just fine, in this case, this is where we're opposite. We're going to irritate that uterus. We're going to try to get it moving. So to do that, we're going to get mom up and moving. Maybe she can still ambulate. She doesn't have that epidural usually placed at this point. It's too soon for that. So she's going to get up and get moving. Maybe we try to up her Pitocin. Or we might go ahead and break her bag of waters if that baby is engaged. Now, a precipitous delivery is one that is occurring way too fast. So from start to finish, a precipitous delivery is classified as under 3 hours. So even though it sounds like a great thing, we talked about in Unit 1 with that normal newborn, all of those transition things that have to happen. Well, a baby or a fetus who has gone through a precipitous delivery is expected to make those transitions to the extrauterine environment very, very quickly. Okay, so when we talk about like the squeezing through the birth canal to expel that neonatal, the fluid within the lungs, that's not going to necessarily happen as much. The twists and the turns that we talk about with the cardinal movements of labor, that doesn't necessarily happen, or it happens very quickly. And in that case, we have concern for trauma to the head. If mom is just shooting out this baby and we don't have a controlled delivery with those hands-on, hands-off, Rickens maneuver, etc., we can also end up with extra lacerations that we may not have had it been a more controlled delivery. And there's also the concern for a maternal hemorrhage, things happening so fast that we end up with a tear somewhere and we just start bleeding. So what we're going to do here is, if we're having a precipitous delivery and we have Pitocin running, suddenly things are moving too fast, what are we going to do with that pit? Are we just going to leave it running? Well, absolutely not. That is something that we can slightly control. So let's pop back on that and see if that slows things down at all. We're going to very closely monitor this mom. Do you think this mom, if she's having a precipitous delivery, are we monitoring that station once every hour? Absolutely not. We're going to be monitoring her station, that fetal station, very closely to see just how quickly things are speeding up or if they're starting to slow down at all. Then too, we can have dystocia related to those secondary powers. So in this case, like, we're talking about a psychological response. At this point, mom is perhaps exhausted. The epidural has worn off or is not working. Throw in there a little bit of trauma, throw in there a little bit of post-traumatic stress disorder, and we are setting ourselves up for a dystocia delivery. So treatment with this is going to be, if we're having some more of that exhaustion or what have you, maybe we need to try to change that position. Give mom a little bit more control over things. We might be able to do a little bit of coaching if it's more of a psychological response and related to trauma. Either way, this baby has to come out, unfortunately, so we'll have to do everything we can to help this mom. At this point, this might be a forceps or a vacuum delivery as well. So dystocia, or a difficult labor that's caused by something wrong with the passageway. So here we're going to talk about issues with the bony pelvis or with the soft tissues, like if there's an obstruction in the cervix that we didn't know about, or within the vaginal canal. something as simple as a full bladder. If you have a full bladder, it's going to prevent that baby from making that fetal descent. Other things that we might not have as much control about would be something like a uterine fibroid. Okay, so if we have somebody with really poor prenatal care, or we have somebody who has had no prenatal care, and they show up at our emergency room, the ED transfers them up to labor and delivery because they're in active labor, and suddenly there's a uterine fibroid that we knew nothing about. Usually those can be picked up on prenatal ultrasounds. Like, we would usually have some sort of clue that they're there. But if we, once again, haven't had adequate or complete prenatal care, that might be something that is missed. So those uterine fibroids can definitely prevent labor from happening. I mean, it's an obstruction. A full rectum, if the mom has been really constipated and we're so full that we're also preventing baby from coming down, that's another concern. And a placenta previa, which we have not talked much about, but again, this is when the placenta is covering that cervical os, where that placenta has, again, like a low-lying placenta. So obviously in that case, we're going to have difficulty related to dilatation and effacement as well. Again, that's something that hopefully we have picked up on a prenatal care visit, prenatal ultrasound, but not everybody follows the rule book. In this case, if there is something related to a passageway dystocia, we can perhaps trial labor, but anticipate an instrument delivery. So, dystocia related to the passenger. So it's not just mom that can inhibit labor. Our little fetus can also contribute very much so. So these include fetal size. For example, if we're excessively large, which is anything greater than 8 pounds, 13 ounces, it's usually diagnosed by ultrasound prior to delivery. Again, we like to have a heads up about these things. With a large baby, there is a higher risk of injury, fracture, and hypoxia.